Three, two, one. Please start.
Yeah. Good evening, respected doctor. On the behalf of team Bayer, I welcome you all in this scientific symposium. So, uh, I would like to invite Dr. Adis Sarin sir. Sir is the moderator of today's evening, and sir is the vice chairman of Department of Medical Oncology, prestigious Sir Gangaram Hospital, Delhi, sir. So, over to you, sir, for proceeding this meeting, sir. Thank you.
Thank you, everybody, and I am happy and super proud that my two young faculty members are here with me and dear colleagues, Dr. Abhishek Sharma, who is the senior consultant, the Department of Medical and Hemato-Oncology at Goel Hospital, Jodhpur, and my dear friend, Dr. Ajit Ratan. He's a consultant in medical oncology at Medanta Hospital, Gurugram. And I think the objective of today's meeting is quite, uh, specific to understand what is the current landscape in the treatment of, CA, management of CA prostate, starting from, castration sensitive and how the things are evolving in this HSPC realm, and where in all this setting, darolutamide has changed the game. So, it, yeah, let's say if I have started patients like 15, 20, 30, whatever patients we have been able to put on darolutamide, all have been doing phenomenally well. So I think this kind of meeting, encourages our colleagues to discuss and deliver more of their experience with the drug and on the data set where they would like to use this kind of a combination. Obviously, it's we all know that it's not going to be used by all, but whenever possible, wherever possible, how to best utilize this combination. So, without a further delay, I think let me invite our first speaker, Dr. Abhishek Raj, who's a senior consultant at Goel Hospital, Jodhpur. And he will be discussing about reaching new heights in metastatic HSPC care. So, over to you, Dr. Abhishek.
Yes, sir. Thank you, Sarin sir, for this invitation, and thank you, Team Bio, for this academic meeting. So I am going to start, and I'll share my documents right now. Yeah. So my screen is visible, and I am audible.
Yeah, both.
Yeah. So definitely, we all are here discussing because as we all know, in the older age patients, the common we are seeing in daily to daily as well as in our OPD, patient presented to us with the metastatic, non-metastatic, incidentally diagnosed prostate cancer. As we all know, in a CRP setting, their PFS, their survival is very bad in a few months. But yes, when you look at the HSPC setting, definitely survival in the years in the recent development, recent researches, and all are the available ARPIs, chemotherapy drugs, and other mutations and all. So right now, HSPC is surviving more and more here. So when I just discussing initially, we as you know initially uh, good risk, intermediate risk, high risk. Right now, very high risk, locally advanced, as we all know, ADT, some kind of chemical ADT and local therapy in form of surgery or radiation is followed by some patient have some kind of biological biochemical recurrence, and they lead to if patient is on ADT, and they lead to the some non-metastatic but biochemical recurrence they consider as a non-metastatic CRPC, and then they finally lead to the metastatic CRPC. And sometime when your ADT is stopped after 2 or 3 years in a local advance or in the local setting, but after that they develop kind of metastasis, they kind of HSPC, you can say that. And definitely patient who suffer and die of prostate cancer all have CRPC. And the treatment of the metastatic CRP, as we all know, OS improvement is just 4 or 5 months after all measurement we have done. So definitely we have to improve our HSPC setting survival. So this is the STEMPE trial, definitely the trial that develop a survival with a newly diagnosed prostate cancer of metastatic in the docetaxel era. The data of around 1,000 patients in the control of the STEMPE trial. But definitely, when you look at this curve at the 5 year survival, you can say with all these, definitely we need to add something else in this data to improve the patient survivals. When you look at the patient with the STEMPE trial, those who have a less than 4 bony metastasis, more than 4 or equal to 4 metastasis, you can clearly see there is a difference in the uh, progression-free survival as well as their overall survival. That's clearly showing what the benefit in this stampede with this whom and for the patients. And this all are the agents. They are improved the survival in the especially HSPC. When you look at the GET UG trial that developed docetaxel followed by charted the subsequently of docetaxel improvement followed by stampede with the abiraterone as well as docetaxel. Latitude develop a improvement in the OS and PFS with the abiraterone. RCs with the enzalutamide, Titan for the apalutamide, Enzamet for again enzalutamide. Peace one trial right now all of are using their developed abiraterone with some combination, and arsons definitely dilutamide plus docetaxel. So this is the development of the therapies with the mean time for the especially HSPC setting. So definitely we have a wealth of data supporting concomitant therapy. So what we do, we choose. So we are going to discuss all of that. When you look at the charted docetaxel in the HSPC setting for a high volume disease, median was around 51 month versus 34 month, good hazard ratio 0.6 and significant p value. Improvement in the OS you can say around 17 month, but when you look at the low volume disease, there is no clear cut benefit in hazard ratio is 1, no significant p value, and no survival in the overall survival. There is no improvement definitely. So you can clearly see charted suggested the benefit only in the high volume disease. When you look at the latitude trials, they develop the abiraterone especially in the high risk metastatic HSPC. And yes, there is a improvement. This is abiraterone was the first to show the hormonal treatment can be effective, and it is important to understand to treatment journey in the control arm. For this all of data, you can clearly see the benefit in the PFS as well as OS shown by the high risk metastatic HSPC in the latitude trial by the abiraterone. So, consideration of the abiraterone, you can clearly see we all know the management part of the abiraterone, especially hypertension, some kind of hypertoxicity, hypokalemia, cardiac disorder, and definitely we all are using steroid. So somehow it's sometimes it's hampered to us, especially in the uncontrolled diabetic patients. When you look at the data of apalutamide, especially uh, versus ADT versus apalutamide plus ADT, but they compare with the ADT, p-value significant, good risk hazard ratio, so benefit showing in the PFS as well as OS, or showing benefit in the both low volume group as well as high volume group. Second data is about the Enzamet. Enzamet is developed the data with enzalutamide plus ADT versus ADT, and you can clearly see there is a clear-cut benefit in the both volume group, high volume and low volume, as well as when you look at the clinical progression-free survival hazard ratio, that is zero point 0.4, and the overall survival hazard ratio is 0.6, and p-value significant. So these are the trials is showing their importance in HSP setting in the improvement of the progression-free as well as overall survival. But so this is a study definitely a game-changing study that changed the uh, era of you can say the new era of the HSPC. The excellent improvement in the survival when they combine chemotherapy with the some kind of ARPIs. So this study conclude metastatic HSPC around 1,000 patients they include in the study. All are the de novo M1, recurrent M1 they didn't included. So they are one of inclusion criteria less than 3 months of ADT prior to randomized, no prior chemotherapy, and same most of same stratification as other trials like PAS, metastatic area, type of castrations, and docetaxel yes or no. So they randomized up to standard treatment arm versus plus chemotherapy versus abiraterone, chemo plus abiraterone. So they all are studies in this trial. So you can clearly see the benefit in the PFS part with this trial. In the high volume, there is a clear cut benefit, but in the low volume, there is no excellent benefit. So this trial, hazard ratio and p-value, you can clearly see in this Kaplan-Meier. So that led to confirmation that high volume disease, you could improve outcome by adding abiraterone to docetaxel versus docetaxel alone. But in the low volume disease, it didn't seem to be a beneficial as high volume disease. So definitely we all are using in this. So now move the arson studies. So the the one of the excellent study right now we have with the combination of ARPI plus chemotherapy. So same metastatic HSPC setting patients with the good ECOG candidate for the ADT and docetaxel stratified according to the M1A, M1B, or M1C, and definitely alkaline phosphatase level. So on the basis of they all are advised, and around 90% patient receive 6 cycle of chemotherapy. They trial done a placebo plus docetaxel versus placebo plus dilutamide 600 BD with ADT. And the primary endpoint is the overall survival, and secondary endpoint list of the time to castration prostate, time to pain progression, skeletal free event, and many other good secondary point they have. So when you look at the OS seen all across the group, hazard ratio, Kaplan-Meier, separation, that looks good in all. When you look at the high volume, high risk and low risk both, good significant hazard ratio, good separation of curve. So we can clearly see with this combination, there is a clear-cut benefit in the overall survival in all subset. When you look at the secondary efficacy point, time to CRPC, time to pan progression, time to subsequent first antineoplastic therapy, time to first skeletal associated events. So there is a clear-cut benefit with this combination in the all kind of secondary endpoints. When you look at the PSA response and outcome, you can clearly see undetectable PSA with this combination is when you look at the bar, definitely this showing this is more superior to the IDT plus docetaxel. And when you look at the survival for the patient, those who have a undetectable PSA at week 36 versus those who have detectable PSA at 36 week, there is a benefit. Those who have a undetectable PSA at the 36 month. So that's clearly showing this drug, this combination is doing better. Time to PSA progression, definitely good hazard ratio as well as. And when you look at the high volume HSPC, they more or less showing some good improvement, especially dolutamide triplet achieved long periods of no disease progression and also significant improvement in the OS. So high volume disease, you can say they are all doing better to improve the undetectable PSA timings as well as their survival as well as PSA progression also, as well as you can say the time to CRPC progression also. And when you look at the low volume HSPC, excellent response you can clearly see in this all our bars and overall survival. So these are clearly showing all secondary points, all primary point achieved with this combination. So with this combination, we clearly see benefit in the OS seen in the both groups, low and high. Overall population also showing the benefit with hazard ratio and p-value significant. When you look at the time to pain progression, there is a clear-cut benefit. When you look at the skeletal retrieval benefit, you can clearly say pain symptomatic benefit. There's a clear so benefit. When you look at a response rate to PSA detectability, yes, definitely high at 36 week when you are just combination. And that patient, those who have undetectable PSA, definitely their survival is good. So this touch the all criteria, you can say they tick the all boxes. So things to consider: patient those who are tolerant or accept to docetaxel. What is the high volume? What is the extent of disease? Likelihood some hormone insensitive clause. Patient age, life expectancy. So this is the concept of definitely oncology. Hit hard and early. So definitely it works on a prostate because prostate cancer will be the cause of death. So will docetaxel be an obligation in the near future? Much less effective post ARPI progression. So definitely patient need to be informed all of the option available. So that's the things to be considered for that, especially in the triplet or HSPC setting. So thank you all of you.
Well, obviously, I think, Dr. Abhishek, you have highlighted one of the most important points where, this drug has shown all these drugs are showing a phenomenal improvement in high risk and high volume more rather than being disease being in the low volume. So, have you have any patient where you have been able to use the quadruplet, let's say, low volume disease or a high volume disease where you have been able to add radiation on top of the triplet? And if
No,
yes, then
sir.
how has your experience been?
No, sir. In whenever patient is affordable for our dolutamide, so I am just going with the dolutamide and docetaxel combination with the skipping of radiotherapy. But yes, sometimes there are low volume disease, those who are not affordable for dolutamide and they are not choose the option of dolutamide, then definitely I choose the radiotherapy, especially in the low volume, even in combination of that basis on the piece one approach. Otherwise, those who
Right.
are on
And
lenalidomide, I just skipping radiation in this.
how if we would talk about the affordability at your place, what do you feel that out of 100, how many can afford this drug?
So that's a part difficult to, for me. Around 1 to 2% cases are only affordable,
1
sir.
to 2%. So that's,
Yes, sir.
I think, and your experience still, I mean, since you have been prescribing this drug to all those 1 to 2%, have you found any difficulty or any benefit like the data says that this is the only drug available which causes one of the least drug-drug interactions. And if you see the neurocognitive decline, it is least with the darolutamide as compared to the
Yes, sir.
other amides available on the market.
Yes, sir. So definitely when patient comes to me, I generally explain the data of arson with the docetaxel and darolutamide, as well as I have to explain the piece one also. So sometimes you can
Yeah.
say that abiraterone is easily available in Rajasthan, sir, in the all kind of yojana as well as all kind of insurances. So most of patients choose abiraterone. It's very difficult for me to convince for the darolutamide, especially those who are educated ones, those who have any kind of uncontrolled diabetes. I am going to use steroid in this abiraterone, then definitely they convince with me with the all data. Otherwise,
Mm.
it's very difficult to convince the patients. But right now the increasing, but are increasing in the time, sir, because patient right now investing some things. Yeah, this that going to be better with us. Right now we have some comorbidities, so yeah, right now my use of dolutamide is increasing, sir.
Yeah, we have Dr. Ajit Ratan with us, who is working at the flagship corporate hospital. So tell me, sir, darolutamide, your take. You are muted, sir.
So, am I audible now?
Yeah,
Yeah.
absolutely.
So,
He
excellent
says
drug.
that, the cost is an issue, so only 1% can afford. And I think in
Yeah.
your center, it must be 99% patients must have been able to afford.
Mu- Much less than even 1%, to be honest.
Oh
Uh,
my God.
it's an exciting drug. The problem with darolutamide is it's an indefinite therapy. So, cost becomes an eventual limiting factor. So, I have a couple of patients on darolutamide. One of them, very interesting, is somebody who has had progression on uh, abiraterone as well as docetaxel and has bone marrow infiltration, and he has very little
Hello, good
platelet count
evening.
of around
We are
30,000.
going to start the conference. First,
Yeah, yeah. Am I
So
audible?
can you, yeah, I can.
request
Yeah, yeah. So he, after discussion, because bone marrow involvement was leading to a lot of complications requiring blood transfusions and platelets were also less, he was not offered any cytotoxic therapy after docetaxel. Neither your lutetium therapy was, he was not a candidate for that as well. So for him, I actually chose uh, darolutamide after multidisciplinary conversations with a lot of colleagues as well, and we realized that it actually started working. His platelets increased, his requirement for blood transfusion actually went down. So whenever we talk about one ARPI acting after the other, I think for me it was an eye opener that after the biraterone I had this darolutamide acting in this situation, and even in a disease which had gone to an extent where the bone marrow was involved. Dr.
So
Joy,
I think this
who's
is
like
where I
sitting
need
beside you,
your
would also know
opinion
about that.
now, your journey from CSPC to CRPC. Can you delay the inevitable? So over to you, Dr. Ajit, now for your talk.
Thanks. Yeah, sure, sir. Let me just share my slides, share my screen. Yeah. Yes. Fast. Okay. How do we do it? Just give me a moment. So yeah, my topic is metastatic HPCs, hormone from hormone metastatic hormone sensitive prostate cancer to metastatic castration resistant prostate cancer. Can we delay the inevitable? We cannot prevent it, but the question is, can we like delay it? Uh, the slides have been prepared for scientific and educational purposes by registered medical practitioners and have been provided to me by Buyers International. Uh, so we all know that the treatment of metastatic HSPC is ADT with one of the ARPI, irrespective of the timing of metastasis, risk volume burden. And there is also co-administration of docetaxel in such situations as well, and the role of therapy, which has been used on case-to-case basis. However, there is no role of intensification of docetaxel alone, as has been demonstrated by piece 1 and Arasens. Dr. Abhishek pointed out. The early intensification
I think
strategies in
there is
metastatic
a pop-up
hormone.
going ahead, Dr. Ajit. Can you, there
Yeah,
is some pop-up.
how
Is it
do
only
I?
visible to me
Yeah.
or everybody else?
No, it's visible to me as well.
Okay,
So
okay.
that's actually the I'm sorry, that's actually the Zoom link that is coming. So
It's
that's causing the problem. Yeah, how do we?
Amit, do you
I
have
don't
his
think. I,
slides? Do you have Ratan sir's slide over there?
Sir,
yeah, yeah,
sir,
yeah.
can
I think
I?
it'll be.
Yeah, no, it's
I think
gone.
it'll
It's
be.
gone. You can start. You can start.
It's
Go
gone,
ahead.
right?
It's gone.
Right.
Yeah,
So there is no role of intensification of docetaxel alone. Uh, the American Association of Urology also tries to tell you that number one, adequacy of life expectancy is important in making these decisions. If the life expectancy is less, such questions do not arise. But if the life expectancy is high and the patient is further divided into low volume and high volume, the low volume in the low volume situation, we do usually use EBRT with either abiraterone, apalutamide, or enzalutamide. But now, after the Arasens trial, we now know that there is a role of docetaxel with apalutamide as well, because the benefit was present in low volume disease as well. High volume disease has been pretty much uh, something that we've had no confusion about. Docetaxel 6 with either abiraterone prednisolone combination or docetaxel 6 with darolutamide uh, is the favored triplet combination. So the question for today is, who are the ones for docetaxel eligibility? And that's the most important question that we have to answer in our clinic when the patient comes to us with a high volume or either a low volume metastatic hormone sensitive prostate cancer. So which patients with metastatic hormone sensitive prostate cancer benefit from docetaxel? The systemic review and meta-analysis from randomized trial was done, and they realized that pretty much the high volume synchronous disease patients have an established benefit. You can give in high volume metachronous disease as well, but the low volume synchronous or low volume metachronous disease, there's a consensus that giving only docetaxel doesn't give a good OS advantage to such patients. So you can use docetaxel sequentially in these patients after progression. So, which patients benefit from docetaxel? Again, the high volume, the high stage 4 disease, the benefit of addition of docetaxel to the Kaplan-Meier curves is much marked than just ADT alone. So, the standard treatment of any metastatic HPCC, HSPC is any one of the AFPI, irrespective of the time of metastasis, volume burden, and co-administration of docetaxel with plus minus radiation. Coming to the RSN study, which was described by our previous speaker, Abhishek, it was the only study prospectively designed to darolutamide ADT with in metastatic hormone sensitive setting. So this had to be less than equal to 1. Candidates for ADT and docetaxel stratification was done by extent of disease and alkaline phosphatase level. Around 1,300 were randomized 1:1 to the standard, which was the C plus ADT plus docetaxel 6 cycles, versus the testing arm, which had the addition of darolutamide 600 mg BD with AT and docetaxel. The primary endpoint here was OS, which is a great thing to have in a trial. But there were few key secondary endpoints as well. One was the time to castration-resistant prostate cancer, time to pain progression, symptomatic skeletal event-free survival, uh, initiation of subsequent antineoplastic therapies, time to worsening of physical symptoms, and time of initiation of opioid use with 7 consecutive days, as well as safety. The final analysis was conducted after 533 days, and secondary efficacy endpoints were tested hierarchically. The first cycle of docetaxel was administered within 6 weeks after the start of the drug at the discretion of the investigator. In respect, the piece one was not a prospectively designed study and it had a very complex design. First of all, it had a very sort of confusing randomization of 2:2 factorial design with 1:1:1 randomization between the groups. They did not include the recurrent metastatic patients which the Arasens had, and prior chemotherapy was not on these patients. The performance status, the use of AT less than 3 months were also prioritized. No prior chemotherapy had to be taken. The certification was done based on ECOG performance status, metastatic sites, types of castration, LHR agonist versus antagonist versus orchidectomy, and the use of docetaxel, yes or no. So there were four arms. Arm A was the standard of care. Arm C was standard of care plus radiation, and there was then pooled into Arm B and Arm D, standard of care plus abiraterone plus prednisolone. And your finally your Arm D was standard of care plus abiraterone plus prednisolone plus radiotherapy. So confusing in that sense, where not all your patients in the standard of care arm received docetaxel, and we'll see eventually how many eventually did. So piece one was amended to allow for the evolving standard of care with docetaxel. In from November 2013 to 2015, only ADT was preferred in patients, around 273 patients. From 15 to 17, they realized that docetaxel now has joined to so those 5 patients from time period received docetaxel, and then from 2017 to 18, docetaxel was mandatory in these situations. However, if you compare it with the Arasens, all 1,306 patients enrolled received docetaxel versus 710, only 61 patients in the phase 1 trial. So a little bit of comparison, although we know that these studies show different clinical scenarios and include different patient populations, and they're not intended to compare, but comparisons are inevitable in such situations. So Arasens had both recurrent and de novo hormone sensitive prostate cancer metastatic. Piece 1 only had de novo metastatic hormone sensitive prostate cancer patients. The primary endpoint was OS in both. Stratification factors in Arasens was extent of disease, ALP levels, whereas in Piece 1 it was type of castration, ECOG performance status, extent of disease, docetaxel, yes or no. And the combination analysis in Arasens was pre-planned. 100% of the patients had to receive ADT plus docetaxel in both the arms. And whereas in piece 1, the standard of care evolved from ADT alone to mandatory ADT eventually, and only 61% of the patients received the ADT plus docetaxel as standard of care. So exclusion criteria of Arasens was pretty much straightforward. Any contraindication to docetaxel like stroke, MI, unstable angina, coronary peripheral artery disease, congestive heart failure. Piece 1 also had these contraindications, had these exclusion criteria. There was, although, an additional contraindication to prednisolone or that is being used with abiraterone. So less of such patients were selected. If you can see the Kaplan-Meier curves, the darolutamide plus ADT arm versus docetaxel showed significantly reduced rates of death. The risk of death was reduced by around 32.5%, with hazard ratio being about 0.68%. And as you can see, after 4 years of follow-up, 13% or 13% more patients were alive, doing well, when darolutamide was added to ADT plus docetaxel. Similarly, the combination results with piece 1 trial also showed the benefit of adding prednisolone, abiraterone to ADT and docetaxel, and the results here also showed a good OS advantage with a hazard ratio of 0.75. But unlike in piece 1, in Arasens, there was an early separation of the Kaplan-Meier curves, and the lines remained separated over time. And coming to the duration of therapy, more patients, or in other words, patients in darolutamide remained on darolutamide for more number of months than the patients who received abiraterone in the piece 1 trial, just as a comparison between abiraterone and darolutamide. So the median duration of treatment in Arasens was about 41.3 months in patients who were still receiving darolutamide. However, in piece 1, the median duration of abiraterone was only 34.1%. A majority of the patients had to discontinue their therapy because of the side effects associated with abiraterone. Around 17% of the patients in the PEACE-1 trial had to stop abiraterone because of intractable side effects. Whereas in darolutamide, it was pretty much similar with the placebo arm, and it was only 13.5%. And the darolutamide did not affect the ability to complete all full cycles of therapy, as has been explained and has been reiterated over and over. Very little side effects with this therapy, and almost 87.6% patient cycles. The data with PEACE-1 was still not available with us. Again, side effects. If we see the both arms of the RSS, nothing much to choose from. Similar grade 1, grade 2, grade 3 toxicities, even grade 5 toxicities. Probably because of the docetaxel and ADT arm, and nothing much to add in terms of the addition of darolutamide. However, if you see the PEACE-1 trial, there were a lot of severe side effects attributed to the use of abiraterone. Hypertension, as we know, hepatotoxicity, higher rates with this therapy. So that's why some of the patients had to stop these therapies because of these increased side effects. Yeah. So yeah, that's again to reiterate, standard of care is a triplet therapy with plus minus radiotherapy, and there is no role of intensification of docetaxel alone as demonstrated by PEACE-1 and RSS. So in patients with high burden metastatic hormone sensitive prostate cancer that are chemotherapy fit, do you recommend a triplet therapy for docetaxel? This question was asked to the panelists, and majority of the patients said that they would want to favor the use of this triplet combination. Similarly, what do you do in low burden patients? Again, here majority of the patients said even in asynchronous disease, the consensus was most towards the use of triplet therapy rather than a doublet therapy. A little safety consideration with the use of doublet and triplet therapies. For doublet therapies, you have to monitor in case of abiraterone, hypertension, edema, and hypokalemia. Not so much when darolutamide is used. There is the problem of pill burden. If your abiraterone is 250 mg, you have to give like 4 pills per day. So compliance in such cases is an issue, especially for those patients who are to have those innumerable tablets to have for hypertension, diabetes, and those clopidogrels that they have. And there is exacerbation of the ADT adverse effects that happen that are common to both triplet and doublet. There are cognitive and bone issues because of these ADTs. In triplet therapy, all these that are there for doublet therapy are considerations in triplet therapy as well. In addition to it, there is a problem of chemotherapy induced toxicity like neutropenia, neuropathy, fatigue, and there is administration time, there is infusional treatment, more resource utilization in resource. So the message is studies PEACE-1 stated that ED plus docetaxel is not enough. There is a scope of addition of ARPI to improve the survival. Additional intensification with triplet combination approach should be considered as a new standard of care in patients with metastatic HSPC. To proactively manage patients' adverse events for now, treatment options to optimize treatment outcomes, and multidisciplinary key is the key to success. So all eligible patients should be offered the benefit of such treatments. A few questions for everybody. If Dr. Abhishek and Dr. Sareen are there in the meeting. So the first question is, which patient phenotypes would likely tip you towards the use of tablet versus triplet therapy? Dr. Abhishek or Dr. Sareen, any one of you can answer the question.
Yeah, I think so. The answer over here is pretty much very simple. I think first of all, patients with having a visceral involvement disease, those are the patients where I'll be going for the triplet. And if the symptoms are too much and the patient is there in the visceral crisis, obviously, then I'll be starting with the low dose intensity of the triplet and then gradually build it up as soon as the bulk of the disease has been handled. Well, frailty is another important point, and you know that most of our patients are elderly. So at least to begin with, you can start with the doublet and add on triplet if the modification requires. But I think doublet can also work over there.
Fair enough. Fair enough. Then the question that is always there is, what do you do in case the patient has uh, common practical problems like he has issues with steroids, cardio risk, and CNS related concerns. I think the answer is pretty much straightforward. The
Yeah, absolutely, absolutely. This is where
darolutamide,
this,
yeah,
yeah,
yeah, yeah.
this is it. It takes away all these thought process, in
All
one
the
go.
yes,
That
yes,
yeah,
yes. Yeah. And the third question is, how does a volume data clarify the appropriate patient for treatment intensification with the darolutamide plus ADT plus docetaxel? So now, would you use it for low volume as well, or would you just keep it for high volume patients?
so it's something like this. I won't be very much inclined to 100% go in for the low volume, but then
Agreed.
again, I can get away with the doublet as well. So it's not a necessity to use it in the low volume, but I think, uh, and
I
to be
think there
honest,
are
you
other
don't
issues.
get low volumes.
Yes, yes. I think there are other issues as well. Sometimes low volume is just a snapshot of
Yeah,
the image that you're having, and the disease actually is very aggressive with
yeah,
your high PSAs and everything. And then your low
yeah,
metastatic volume burden is actually just uh, it's just a picture that you've had on a PET CT, and they eventually turn out to be
yeah,
those aggressive ones. So you have to really be careful about what the disease is, and yeah, and look out for these additional data points that will help you decide whether this is an aggressive disease or not.
yeah.
Yeah. Agreed, agreed, Dr.
Abhishek is there.
And
Dr. Abhishek, are you there?
yeah, I think he was driving, so he must have
I think,
muted
yeah,
himself.
yeah.
So, how do you interpret these efficacy and safety results when choosing a combination partner for early treatment intensification? I think, Dr. Reem,
Yeah,
you will agree, given a chance, we would all want to use darolutamide as well as the combination of
yeah.
docetaxel in all our patients. So that's pretty much covered.
I think as a thought process, what I would be keen on using the triplet to make sure,
Mm-hmm.
the triplet is there. And obviously, if,
Mm-hmm.
everything falls according to the plan, then obviously why not to use darolutamide in that?
So, have you ever used docetaxel in like weekly to weekly regimes because you're not more comfortable about the patient's tolerability of a 3 weekly docetaxel? Have you ever tried that?
So I
I
have
have for
used two
some
weekly,
patients.
and
Uh-huh.
yeah. I mean, I have dialed down docetaxel usage. I mean, I have in one
Mm-hmm.
patient I have tried in the weekly fashion as well, and then gradually up titrated it to the 2 weekly. 3 weekly docetaxel, it's a difficult drug, and
Yeah,
let me be honest, it can give you multiverse of side effects if it wants to give you side effects.
yeah. Not an easy drug to be. Yeah.
Yeah,
Thank you so much, everybody. Dr. Sareen, thank you so much for being a patient listener and
thank you.
contributing to the research. Thank you.
Always, always. So I think we move on to the last segment of this conversation. And Amit, do you have my slides or shall I pull up?
Yes, sir. Just give me a minute. I will upload from my side.
Yeah, I think even I have it. No, it's okay. I
So
will,
should I proceed, sir?
yeah, I will share. So give me, you can convert the host settings. Okay. Okay, you have already my slides on. Fair enough. So, Nubeca in clinical conversation. So next slide. Next slide. So, here we'll be discussing a gent who is middle-aged Go back to previous slide. 64-year-old, no major comorbidities, and ambulatory, conscious oriented, and was found to have elevated PSA, leading to the diagnosis of CA prostate, and no other major symptom other than a mild low backache at the time of examination. Next slide. So PSA was 438, and Gleason here you can see it is to the tunes of 5+4, and a GG which is grade group 5. Next slide. So these are the findings of MRI, and considering the patient was symptomatic from the lower back ache, so we got it done, and there were like multiple visualized vertebral body and posterior elements having altered signal intensity, and then there were similar signal intensities in sacrum, iliac, and enlarged nodes in the para-aortic, inter-aortic cable, paravertebral soft tissue involving the light source, and it was suspected metastatic disease. So next slide. So we got the scan done. The scan showed FDG avid lesions in the posterior peripheral zone of the base, mid gland, and apex of the prostate with retroperitoneal, common iliac, pararectal, left level 4 cervical node, multiple bony mets, both appendicular and axial skeleton, and it was suggestive of a M1 CASPC prostate with nodal and skeletal mets. Next slide. So this is what patient presented to us with. And you can see the sheer bulk of the disease. I think it's all the bones are lighting up nicely on the PSMA PET scan. So Dr. Abhishek, are you here with us?
Yes, sir. I am just joined, sir.
Right. So here is the PSMA PET scan. How will you approach this case?
Sir, can you just summarize? I just missed this because
Yeah,
I just.
middle-aged,
Yes, sir.
438 PSA, multiple
Okay, sir.
bony mets, and if you can see on your screen the
Yes, sir, I can see that.
multiple, yeah, you can see the multiple bony lesions. I think all the bones, multiple lesions are there. It's a bulky
Sure, sir.
disease.
I got it, sir. So, definitely,
Yeah.
sir, this
So
patient
how will you
presented.
take?
Definitely, sir, this patient presented to us like a metastatic adenocarcinoma prostate, and definitely this is a de novo patient. So I will consider as a metastatic hormone-sensitive prostate cancer. So I think all workup was done with the MRI and PSMA scan, and biopsy already we have. So I just counseled this patient for the treatment part. So that basically right now that we all discussed the data, that piece one approach as well as arson, and definitely I choose the arson, and I definitely completely explain the patient about all the benefits. If he affordable and he's willing, definitely I'll choose the docetaxel with dolutamide as well as some kind of systemic therapy, symptomatic therapy also. Due to pain, rest will continue.
So here is one, I think D7 or D8 vertebra. It was compressed. It was having a wedge compression fracture as well.
Yes,
So
sir.
your question is, do you think bisphosphonates or rank ligand inhibitors add something over here in patient who is already having a SRE on at the time of presentation?
Yes, sir. I think, but the in HSPC setting, there is a no excellent clinical benefit shown with the bisphosphonate, sir. There is some benefit with the denosumab Renkel inhibitor, but with the bisphosphonate, I think, sir, there is no benefit. We clinician, I think, using some bisphosphonate due to because patient on IDT 6 monthly, but there is no proven data in HSPC settings.
So I think if you already have a SRE, you can still use it. And if you feel the patient is severely osteopenic and bound to land up with more fractures, these are the select indications where you can use these bisphosphonates serang. I think other than that, if there would not have been any fracture and the bone health would have been absolutely neat and clean, obviously nobody of us would like to give
Yes,
denosumab.
yes, sir,
So
definitely. For this patient, we can offer because patient is already SRE symptoms. But I
yeah.
think rest is, I think, no clear
Rest,
benefit with the
yeah.
cortisone itself.
No
Yes.
clear benefit. Absolutely right. Absolutely right. So we went ahead, and it's a very recent case, I think 2, 3 days back only. And we have started him on the triplet. So next slide. Next slide. So we gave darolutamide with docetaxel, with Firmagon, everything. He got the best of the best. And now he's coming up in the OPD, and we have just given him, cycle. So yeah, next slide. So this was the case. So we'll just have a few rounds of discussion. And I think Dr. Rajit is not here. So Dr. Abhishek, you and I are going to take the discussion forward. So for patients progressing after ADT and RP, drug of choice, drug of choice may be the treatment of choice. Docetaxel may be the treatment of choice. When and why do you postpone TOC use? Dosi, I think. Yeah.
So this patient, that we already treat with this patient the triplet regime, sir.
Yeah.
Kush.
So this is so that is gone now. These are the new set of questions. The case is done. Yeah.
Okay. Okay, sir.
So
So
patients
definitely,
progressing on ADT and RP,
yes,
DOSI
sir.
may be the treatment of choice. When and why do you postpone DOSI use? Where?
So definitely patient, those who are not fit for chemotherapy, because sometimes
Yeah.
patient presented to us like elderly, frail, male, more than 85 year. Many patient comes to in OPD, and due to some
Yes.
comorbidities, they are not fit. And as we all know, there is a capital leak with the docetaxel, high dose of steroid. So sometimes patient is not fit for chemotherapy. Definitely, sir, docetaxel is not the answer for those patients. And definitely for the low volume disease, if we are not using dilutamide, so definitely we can say no for docetaxel in this
Right.
patient. But sir, in the CRPC setting, those who already progress on ADT ARPI, definitely we have only option of chemotherapy. If he's not fit for chemotherapy, then any lutetium-based therapy or on the basis of any MDS, we can plan second line.
Right. Now, Dr. Ratan is also here with
Am
us.
I,
So
am I
next
audible?
slide. Yes,
Yes,
sir.
yes.
We are
Okay.
coming to you with the next slide then.
Okay. Okay.
Who could benefit from earlier docetaxel? So you are a proponent of a triplet or a doublet?
A triplet like all three of us.
Let's say
I dare
Gleason
say.
score is 7 and exact same thing. So does Gleason makes any difference to you when selecting docetaxel?
Sir, not while selecting docetaxel, but Gleason's does give me an idea whether what will be the pace of the disease
Yeah.
in coming time. And if the Gleason's is higher, more chances I'll use triplet rather than doublet.
Yeah.
So Gleason's and your initial PSA levels, they give us a good idea, and even your PSA doubling time does give us a good idea about the pace of the disease. And I think these are the situations where triplet is a must, and you have to find reasons not to give triplet in these situations because it should be a default. So I think in a patient who has high Gleason score and a high initial PSA and PSA is rising, I would add earlier docetaxel. And sometimes you do not get those early responses even with the darolutamide as well. So they are the cases where you would be a little hard pressed to use addition of chemotherapy just to
Right.
get those
Next slide.
deeper responses.
Perfect. Perfect. Does triplet combination add toxicity? Yeah, Dr. Ratan, you can take this one.
Yeah, it does, no question. But that toxicity comes with an added OS advantage. Had it just been a
Yeah.
PFS advantage and we would have not been sure about OS, that you might have questioned the utility of triplet. But since you have an OS advantage, uh, the toxicity, whatever there is, you have to manage it.
You have to
That's our
manage it.
job. That's our job as medical
Yeah.
oncologists.
This is what
I think
we are there for.
right.
Next slide. So in your practice, what characteristics define patients who are ideal candidates for darolutamide therapy versus alternate treatment regimes? So I think Dr. Abhishek here, we need
Yeah,
your expertise.
definitely, sir. For first more part, if he can afford, yes, there will not answer for all. But yes,
Yeah,
those patient, those who have a multiple comorbidities on a concomitant multiple medicines and uncontrolled diabetes, I'll try to counsel for that development for especially
you're
those
right.
candidates. That's it.
Mhm. Any place where you feel, I should not use darolutamide other than the cost issue, where no, this is something where I am happy to use ebiratron or enzalutamide or
Yeah,
avalumide.
definitely some underlying any liver pathology in the patients because in their trial
Mhm.
they also consider on the basis of transaminitis. So that patient I can consider for the Abira, otherwise no.
There are some patients
Yeah,
who are like on
next
20
slide.
medicines. I think in those you can just give a one pill of enzalutamide and be uh,
Yes, sir.
o- okay with it, because I mean this these therapies, this Nubeca comes with a BD dosing, I guess. So that sort of increases your pill burden a little higher, more than an
But
enzalutamide would.
But then, darolutamide has one of the least DDIs among all
Yeah,
the
yeah,
amides.
agreed,
So
agreed.
if you give enzalutamide, then there can be a high chance of CYP3A inhibitors and those inducers to get
Yes,
trouble
yes.
into.
It's a
And
it's a double-edged sword.
so I think even there, it makes more sense to give a darolutamide, even if the pill burden is high, if you have a polypharmacy. So because DDI is very important, because these patients are 82 years old, must be on the X number of medicines, starting
Mhm,
from
mhm,
Rosuva's, that also contains three drugs
mhm.
if you are taking Rosuva's Gold,
Yeah,
and
yeah,
then, further on with the
yeah,
list.
yeah, yeah.
So, yeah, obviously you have to individualize as per the patient needs. So, right.
I was just trying to nitpick some situations.
Cost, then the cost comes. Next slide, Amit. Next. So I think Dr. Ajit, you can take this. If efficacy is comparable across the RPs, should preservation of quality of life become the primary factor driving the treatment choice in patients with
I think yes.
MHSPC?
I think yes. There are the only two parameters which actually make sense in a clinic is whether this drug improves the survival. That's the first question. And the other is whether, if it doesn't improve the survival, does it improve the quality of the life? So
Yeah.
quality of life becomes an important issue in situations where we know the efficacies are pretty much comparable and we don't know which drug is better. That helps us choose the drug which is better in quality of life. We choose that. We have been doing it in other
Yeah.
situations in oncology as well. So no reason not to do it in this situation as well.
Dr. Abhishek, your final words.
Yes, sir, definitely. For the prostate cancer patient, as we all know, if it's a it's just a good or intermediate high risk, when the patient life expectancy is very less, we still didn't treat the patient. Just told him कि बस आपके पास कुछ साल हैं, just जाओ.
Absolutely.
So this kind of definitely patient we see in the prostate,
Mhm.
so definitely their quality of life matters to us, sir.
Mhm.
So those
Right.
drug, their efficacy is good, and they maintain the patient quality of life. They should be the preferred ones.
Perfect. So I think this was my last slide, and I have had the opportunity of two fantastic colleagues of mine, Dr. Abhishek Sharma and Dr. Ajay Zadan, who has been phenomenal in doing their job and explaining to us what's the journey in CSPC and how from CSPC to CRPC happens, and what should be the treatment selection criteria for our, newly diagnosed CA prostate cancer patients. So back to you guys, and over to you.
Thank you, Dr. Salim. Thank you so much.
Thank you, Dr. Aditya. So thank you so much for respected clinician for joining this scientific event. And definitely we will continue this type of the scientific symposium. And I would like to thank you, Dr. Adi Sarin sir, Dr. Abhishek Sharma sir, Dr. Rajit Rajan sir for joining and making insightful discussion. So thank you all and good night.
Good.
Thank you,
Thank you.
sir.
Thank
Thank
you.
you.
Hello, sir. Can I close the session now? Hello, sir. Can I close the session now? Hello. Hello, sir. Can I close the session?